Hi, my name is Brian Kaufman. I'm one of the pediatric orthopedic surgeons at Central Texas Pediatric Orthopedics. We're located in Austin, Texas, and are proudly affiliated with Dell Children's Medical Center of Central Texas and the University of Texas Dell Medical School. Scoliosis is a three-dimensional deformity of the spine that occurs without a known cause. We're going to talk about idiopathic scoliosis. Idiopathic means that there is no known cause for the condition. Scoliosis can occur as a result of a number of other conditions like cerebral palsy or other neuromuscular disorders. This discussion really applies only to the otherwise healthy child who does not have a known cause for their scoliosis. The three planes of deformity for scoliosis begin with the frontal or coronal plane. This is the S shape that typically occurs on an X-ray. The spine curves in this direction while it's also curving from the side and rotating. When we look at an X-ray, this is the easiest plane of deformity for people to understand and also helps to guide our treatment. At the same time the spine is curving on the frontal or coronal plane, it tends to be flattening from the side. In a child who does not have scoliosis, we expect to see more sway in the lower back and more rounding in the upper back. Those planes of motion are lost when you develop scoliosis. Finally, as the spine is curving from the front and the side, it tends to rotate. This means that the ribs, which are attached to the spine, spin as the spine curves. This rotation of the spine causes the ribs on the outside or convexity of the curvature to stick up or be elevated. This creates the typical rib hump deformity that so characterizes much of scoliosis. The diagnosis of scoliosis often begins with a physical exam. In many cases, your pediatrician is the first one to suspect that your child may have a curvature of the spine. When we look at a child from the back, we can see that one shoulder may be elevated, there may be some asymmetry to the creases on the sides, or the trunk may be shifted to one side or the other. The Adams forward bend test is the classically described exam where the child bends forward and tries to touch their toes. Because of that rotation of the spine, you will see a rib hump deformity on the outside or convexity of the curvature. The diagnosis of scoliosis is confirmed with full-length x-rays. Here you see a full-length x-ray of a child with and without scoliosis. Your spine surgeon prefers to have a full-length x-ray in order to obtain a full picture of the spine as opposed to x-rays showing just portions of the spine separately. It's also important to have an x-ray from the side to demonstrate that loss of the normal kyphosis of the spine. On x-ray, scoliosis is defined as a curvature of the spine greater than 10 degrees. The curvature is assessed by what is called the Cobb angle. The Cobb angle is obtained by measuring the tilt of the vertebra at the top and bottom of the spine as demonstrated here. At its core, scoliosis is a problem of asymmetric growth of the spine. The two major factors that affect how we treat scoliosis are the degree of the deformity itself as well as the amount of growth remaining. When we assess skeletal growth remaining, there are a number of factors that come into play. For our female patients, menstrual history plays a large role in determining at what point in growth the child is undergoing. We also look at things like chronological age in years, growth plates around the pelvis on your spine x-ray, and growth plates in your hand. It turns out that the growth plates in your hand are the most accurate way to assess how much spinal growth you have remaining. The more open the growth plates are in the fingers, the more spinal growth remains. A staging system described by Dr. Jim Sanders, going from 1 to 8, is used to classify the degree of growth remaining. The majority of patients who have scoliosis are in a stage 3 or 4 and reach skeletal maturity when that stage of the hand has reached 7 or 8. The second factor that goes into treatment is the size or magnitude of the curvature. For curves that are less than 10 degrees, no treatment or observation is required. These children do not have scoliosis and do not need to be followed by an orthopedic surgeon. For young children, it is still possible for them to develop a curve, and we suggest continued routine monitoring with your pediatrician. For curves between 10 and 25 degrees, observation is required. Especially with significant skeletal growth remaining, there is a risk that these curves may progress to greater magnitude or size. We recommend an x-ray every 6 months to ensure that the curve has not increased significantly. For curves between 25 and 40 degrees, our typical treatment requires the use of a scoliosis brace. A scoliosis brace is only effective if the child is still growing. This is where determining the bone age from an x-ray of the hand is particularly important. Surgery is recommended for curves that are greater than 50 degrees. Surgery is a difficult discussion, and we have a separate video on that topic for you. The goal of bracing in scoliosis is to prevent curve progression. In some cases, particularly in very young children, we can obtain a more permanent correction of the curve. Ultimately, however, our goal is truly to prevent progression onto surgery. There are many kinds of bracing that can be used in scoliosis. Your surgeon will discuss different bracing options with you. The most typically used brace is a thoracolumbar spine orthosis, or TLSO. These braces are often named after the city in which they were described, such as Boston, Providence, or Wilmington. We also use braces that are modeled off of a three-dimensional CAD/CAM computer-assisted generated model of the spine. These braces are described by Drs. Rigo and Chenot from Spain. An example of a scoliosis brace is seen here. These braces are hard plastic shells that open either in the front or the back and are custom molded to fit the child. The goal of the brace is to push on the apex or the convexity of the deformity to correct the spine. Relief holes are cut on the opposite side so the ribs can go into that hole to allow the spine to correct. These braces are typically worn for a minimum of 16 hours per day. The exact amount of time you need to wear your brace is dependent on the degree of your curve, your skeletal growth remaining, and your surgeon's preference. We are very sure that bracing is an effective treatment for scoliosis. A large randomized control study from the New England Journal of Medicine in 2014 demonstrated that up to 90% of children can avoid surgery with effective scoliosis bracing. The key is compliance with bracing. We know how difficult it can be to wear your brace for 16 hours per day. But remember, there are at least 8 hours in the day where you're not wearing your brace. As I tell all of my patients, the bracing should become part of your life and not take over your life. If you want to play sports, take your brace off. If you're going to a sleepover with your friends, take your brace off. It's going to be okay. The goal is to wear your brace until you're almost done growing so that we can prevent progression of your deformity onto needing surgery. Most children will wear a brace for 1 to 2 years after they go through their peak height velocity or the most rapid time in which their spine is growing. Braces are changed every 1 to 2 years depending on the growth of the child. Our goal is to have your curve under 40 degrees when you finish growing. Curves under 40 degrees tend to stay that way and not increase throughout the remainder of your life. I'm often asked if there's anything you can do to augment the treatment in your brace. One of the most effective methods to add on to brace treatment is physical therapy. In particular, Schroth Physical Therapy is a set of scoliosis-specific exercises which can be used as an adjunct to your brace treatment. For more information on Schroth, please see our video on that topic. It's never easy to be the child wearing a scoliosis brace. We have a number of patients who've successfully completed their brace treatment and serve as a wonderful resource for our patients entering into the journey of brace treatment. Know that your physicians, nurses, physical therapists, and physician assistants stand behind you in your journey. And remember, with scoliosis, you're bent, not broken. If you have any questions or concerns, please feel free to reach out to our team so we can assist you in helping with anything that may concern you going forward.